Good day and welcome to today's American Lung Association webcast, Asthma Care Coverage Update for 2022. Before we begin, as a reminder, on the left side of your screen, there are multiple application widgets you can use. All boxes are resizable and movable, so feel free to move them around to get the most out of your desktop space. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browsing sessions running in the background that could cause issues. If you have any technical difficulties during the webcast, please let us know via the Q&A box. If you have questions for the presenters during the webcast, you can submit them through the Q&A box as well. Now, I will turn the presentation over to Hannah Green, National Senior Director of Health Policy for the American Lung Association. Please go ahead.
Thank you. Good afternoon, everyone, and happy Asthma Awareness Month. We're really excited to have you joining us today to talk about some of the progress we've seen in coverage of recommended treatments and services for asthma patients in state Medicaid programs over the past year, as well as some of the remaining challenges and gaps that still need to be addressed. We know that coverage of guidelines-based medical management is critical for patients with asthma. It is one of 6 strategies in the Centers for Disease Control and Prevention's Exhale package, which focuses on evidence-based strategies to help control asthma. And so it's really important that we know if the children and families that are served by state Medicaid programs have access to the recommended treatments and services they need to control their asthma and ultimately improve their health. Next slide, please. Here's a quick overview of our agenda for today. I'm going to start with a quick overview of the American Lung Association's Asthma Guidelines-Based Care Coverage Project. I'm sure some of you are familiar with it, but for others, this might be new for you. So we'll just do a quick overview of that. And then I'll be handing things off to my colleague, Jacquelyn Link, to talk about our findings for 2021 to 2022 in terms of Medicaid coverage of asthma guidelines-based care. We're also excited to have Kelsey Lamb from RAMP joining us today. Home visiting is one of the areas that we'll talk about throughout today's presentation, and she has agreed to join us today to talk about some exciting work going on in California to improve Medicaid coverage in that area specifically. And then finally, we'll be joined by a couple of my other colleagues from the American Lung Association to talk about some of our organization's other activities for Asthma Awareness Month. As Bailey said, you can use the Q&A box at any time to share your questions, and we will save time at the end for a Q&A with all of our speakers today. Next slide, please. And next slide, please. So let's jump into the Asthma Guidelines-Based Care Coverage Project. This project was launched in 2015, and with funding from the CDC, every year, the Lung Association tracks coverage of and barriers to guidelines-based care in all 50 state Medicaid programs, DC and Puerto Rico. So what do we do this for? I think the real objective of this project is to create a baseline of data on what is and isn't covered in state Medicaid programs so that we can really bring stakeholders together to have discussions about where the gaps are and what needs to change to, again, make sure everyone has the coverage they need to achieve the best management of their asthma. This project is rooted in the National Asthma Education and Prevention Program, or NAEPP guidelines. When we launched in 2015, we brought together a stakeholder group of experts to help translate those guidelines into components of coverage that we could track in this project. And when the guidelines were updated in 2020, we reconvened another stakeholder group to, again, help us translate those guidelines in components of coverage that we could track. Next slide, please. So this is what we track. The 8 components of coverage are listed on this slide: quick relief medications, controller medications, 3 medical devices. We track asthma allergy testing and allergen immunotherapy. We track lung function testing, which includes both spirometry and FeNO testing. We track home visits, and we track self-management education. Some of these components of coverage have been pretty unchanged since 2015, and as I said, others were updated, as a result of some of the, or added as a result of some of the changes in the 2020 guideline updates. I think one thing I'll just highlight here is we did do a round of data collection last year, really just starting that just weeks after the guidelines were released. that provided our kind of first year of baseline information on coverage of some of these newer areas like pheno testing that hadn't been in the project before. But now we did our second round of data collection, really, a year plus since guideline implementation, really, I think, provides a better snapshot of how plans and state Medicaid programs are starting to change their coverage policies in line with the new guidelines. And so Jacquelyn will talk more about that a little bit later in our presentation. We also know that just because a component of coverage is covered on paper, it doesn't mean that it's necessarily easy for a patient to access it. And so since the beginning of this project, we've also tracked barriers to care, and 7 that we currently track are listed here on the screen as well. We track age limits if they differ from FDA age recommendations for medications or the age recommendations for other services and treatments in the guidelines. We track co-payments because we know that for the families served by the Medicaid program, research has shown that co-pays as low as $1 or $5 can and does deter patients from seeking necessary health care. For devices, we track durable medical equipment to see if patients have to get their devices through a special DME benefit, or if they can get them sort of over at their pharmacy when they're picking up their medications and other things they need. We track eligibility criteria, non-medical criteria. Patients have to have a certain number of emergency room visits or be enrolled in a disease management program for a certain period of time before something is covered. We track quantity limits, pretty self-explanatory. Prior authorization, having to get prior approval from the state Medicaid program or plan before something is covered. And then step therapy, having to try and fail a certain treatment before the one your provider prescribes is covered. So there's more detail, a lot more detail on all of these components and barriers on our website, as well as a full benchmark document for our project. We also have a lot more information on our data collection process, but just a very high level. Each year we review this information for every state Medicaid program, and if the program has managed care plans for every Medicaid managed care plan in that state. We look at publicly available documentation, things like member handbooks, fee schedules, preferred drug lists, to see what is covered. We then send that information to state Medicaid programs to give them an opportunity to verify our findings, and then we aggregate that information and publish it on lung.org annually. The last thing I will mention before I go into a couple of new things that we've added this year is that a number of states have temporary policies in place related to the COVID-19 pandemic, things like waiving copays or changing prior authorization rules. For the purposes of this project, we look at states' permanent policies, and if a state chooses to make some of the policies that are tied to the public health emergency permanent, we would then change the coverage data to reflect that moving forward. Next slide, please. So just a couple of new things I wanted to highlight for this year. As always, if you want to look at your state's coverage data, you can go to lung.org/asthma-care-coverage and click on your state on our map, and you'll get 8 tables that look like this one for each of the categories of care that show coverage as well as the 7 barriers to care that we track. Yes means it is covered by all plans. No means it is not covered by any plan. And varies means it was covered by some plans, or in the case of barriers, the barrier varies by plan. One thing that I will point your attention to are the little plus signs next to a couple of the rows on this slide. And one of the things that came up in our conversation with our stakeholders in 2020 was the importance of raising the benchmark from 1 to 2 for a couple of areas that we track. So we now have a benchmark of 2 covering 2 albuterol and levolbuterol inhalers per month, as well as 2 valve holding chambers per year. And this really arose from, the recognition that children in particular will sometimes need to have 2 inhalers or 2 valve holding chambers in different places in terms of, keeping one at school or one in their backpack, one at home, if they have different caregivers, one at each of their caregivers' homes, and how that has really been a barrier to asthma control, particularly for kids. And so we now, if a state has either no quantity limit for these lines that I've identified, or the quantity limit for all plans in that state is either at least 2 per month for the medications or 2 per year for the device, they will now be recognized with the little plus sign next to their line on the table. So just wanted to point your attention to that. And then next slide, please. The other thing that is new this year is we have some redesigned PDFs that are available on each of the state pages. And these provide really just a kind of a high-level snapshot of this project, of the importance of Medicaid coverage of guidelines-based care, and then at a high level, the coverage in each of the 8 categories for each state. And I think this can be a really helpful starting point to educate new stakeholders, decision makers, others about asthma guidelines-based care. And then if you want to dig in further, we have, like I said, those detailed tables on our website too. So with that, next slide, please. I am going to turn things over to my colleague, Jacquelyn Link, who is the National Specialist for Health Policy at the American Lung Association and the Program Manager of the Asthma Guidelines-Based Care Coverage Project, to talk a little bit more about our findings and our nationwide coverage data for this year. So Jacquelyn, over to you.
Thank you, Hannah. I will be taking us through some of our findings from this year's data collection. Next slide. So we're going to start off with our quick release medications. Those are albuterol and levalbuterol, both in the nebulized and inhaled forms. We found that only 2 states covered all 4 of these without barriers, and 40 states covered these with some barriers, and 10 states had partial coverage. The state had to cover levalbuterol and albuterol both in nebulized and inhaled form to be considered fully covered on our map. As you'll see in the next slide, these were more widely covered than the controller medications. However, it was common to see states that covered albuterol but not levalbuterol, or required patients to try albuterol before moving on to levalbuterol. So of all of the state plans, they all covered albuterol, but only about 41 covered levalbuterol, and 10 had coverage that varied by plan, and 1 state, Puerto Rico, did not cover levalbuterol at all. Of the 41 states that did cover levalbuterol, 33 had a plan that imposed prior authorization requirements for either the inhaled or nebulized version of levalbuterol. Next slide, please. Moving on to our controller medications, this includes inhaled corticosteroids, systemic corticosteroids, and other combined medications. If any of these benchmark medications were not covered by all of the state's plans, the state was marked as having only partial coverage. So of our states, we only had 1 that covered all of these with no barriers, and that was Connecticut. We had 29 states that covered with some barriers, and 22 with partial or varying coverage. Next slide, please. For our medical devices, we checked for 3 medical devices. We checked for nebulizers, peak flow meters, and valve holding chambers. The state had to cover all 3 of those to be considered covered on this map. No state covered everything without some kind of barrier, but we did have 33 states that covered it with barriers, 18 states with varied coverage, and 1 state, which was Puerto Rico, with no coverage. Next slide, please. For allergy testing, we found 9 states covered this without barriers, 34 covered it with barriers, and 9 states had some or varied coverage of allergy testing. Of all of the benchmarks that we looked at, allergy testing and allergy immunotherapy, which is on the next slide, had the most states with full coverage without barriers. These were also the most widely covered services of the benchmarks that we looked at. Next slide, please. For allergy immunotherapy, very similar to allergy testing, we found 9 states covered this without barriers, 33 states covered it with barriers, and 10 states had partial coverage. Again, it is the most widely covered services out of our benchmarks. Next slide. Moving on to lung function testing, this is spirometry and pheno testing. Spirometry measures lung capacity, And FeNO testing is fractured exhaled nitric oxide testing, and that measures airway inflammation. The states had to cover both of these things to be considered covered on this map. So we found that 8 states covered these with no barriers, 17 states covered these with barriers, and 27 states had partial coverage. You might notice this is a pretty sharp change from our allergy services because many states had partial coverage or plans that covered spirometry but did not cover FeNO testing. For example, we found that spirometry was covered by 35 states fully and had partial coverage in 17 states, but FeNO testing only had full coverage in 25 states and various coverage in 24 states, and 3 states did not cover FeNO testing at all. Despite this difference, there has actually been a lot of improvement in FeNO coverage since last year, so just in 1 year we've seen some changes. Previously, 9 states did not cover FeNO testing, and this year that's only 3. Previously, 22 states had various coverage of FeNO testing, and this year that is 24. And previously, 24 states had full coverage of FeNO testing, and this year that is up to 25. So there has been some improvement, but that is why we see a lot of states with partial coverage on this map. Next slide, please. Home visits is, of course, where we see the largest room for improvement for guidelines-based asthma care. We found that 1 state, Connecticut, covered home visits without any barriers. 2 states covered home visits with some barriers. 10 states had partial coverage of home visits, and 39 states had no coverage or no information available. If a state was marked as having partial coverage for home visits, that means that some of the plans offered it, but it was not covered for all Medicaid patients in that state. So this is where we see the largest room for improvement in our asthma coverage. Next slide, please. For asthma self-management education, this is the last of the benchmark data. We found that 5 states covered this with no barriers, 23 states covered it with barriers, 23 states had partial coverage of self-management education, and 1 state, Puerto Rico, did not cover this service. This service could include teaching patients basic facts about asthma, teaching patients how to use their medication or how to use their medical equipment correctly, how to identify environmental triggers, how to use an asthma action plan, or how to self-monitor their symptoms. There's a lot of things that could be considered self-management education that we were looking for. This does not include disease management programs or case management programs that plans could offer to patients with asthma or chronic conditions. We did not consider that to be self-management education. Next slide, please. We also collected information on some limits that may exist in Medicaid programs at a program-wide level. These are limits on prescription drugs that a patient may be able to receive, or limits on the number of specialist visits that a patient may be able to have. Starting with prescription drug limits, we found that 6 states had a prescription drug limit across all of their plans. 2 states had prescription drug limits that varied by plan, and 35 states did not have prescription drug limits, and 9 states we could not find data. These types of limits can impact care that patients receive for asthma, especially if an asthma patient is already using 2 or 3 medications to manage their asthma each month. If they happen to have a comorbidity or contract a virus or need medication for an injury, they might have to choose between medications for that month. Alternatively, if there's an appeals process in order to receive more prescription drugs, that can still cost patients important time while waiting for medication that they need to be approved. And patients may also not have the resources or health literacy to navigate an approval process. So we still consider that to be a bit of a barrier as well. Finally, patients who struggle to manage their asthma might also be seeing multiple specialists, like a pulmonologist or an allergy specialist. and limiting their access to specialists would also make it difficult to receive the best care that they can for their condition. In that regard, we found 8 states imposed specialist limits, and 33 states did not have a specialist limit, and 11 states did not have available data. Next slide. Okay, so some final thoughts on our data collection from this year. Obviously, coverage of asthma home visits and interventions is where we see the largest room for improvement, and is also what another one of our guests is going to speak more on later. We also found barriers are not always immediately clear, and that in itself can be a barrier if a provider or a patient aren't sure how to access a service. That in itself can be a barrier to managing your care. Ensuring full coverage and removing barriers is, of course, the best way to increase positive health outcomes for asthma patients. And I will just direct you again to our website, lung.org, to check out your state's full data and coverage if you want to see more on what we found in your state. Thank you.
Thanks, Jacquelyn. Next slide, please. Before I introduce our next speaker, just a quick reminder that if you have any questions about the information Jacquelyn and I have gone over, please put those into the chat, and we will get to those at the end. So with that, I would like to introduce Kelsey Lamb, who is the Director of Regional Asthma Management and Prevention, or RAMP, serving as the Director since 2002 and provides overall strategic guidance in working towards the organization's vision and mission, ensuring a highly effective organization and innovative, successful programs. With a strong interest in both chronic illness and social inequities, she leads all components of the organization's efforts to reduce the burden of asthma with a focus on equity. So Anne, thank you so much for joining us today, and I will pass things over to you.
Anne, I think you're muted.
Thank you. Good afternoon. Thank you for inviting me to be a part of this great webinar today. It's an honor to be here. I am Kelsey Lamb, the Director of RAMP, which stands for Regional Asthma Management and Prevention. We are a project of the Public Health Institute based in Oakland, California, and our mission is to reduce the burden of asthma with a focus on health equity. We don't provide direct service to people with asthma, but we support those who do. We build capacity, we create linkages, and we mobilize our networks to advocate for policy and systems change. One area of our policy work focuses on our goal of expanding access to asthma home visiting services for low-income Californians with poorly controlled asthma. And if we're able to achieve that goal, we will achieve our second goal of improving financial sustainability for asthma home visiting programs. In this photo, California Senator Melissa Hurtado is introducing a bill to the California legislature that would have done just that if it had passed. Which brings me to the long and winding road of our advocacy on this topic. It began in 2015 after the passage of a federal policy called the Preventive Services Rule. This rule would allow state Medicaid agencies to submit what's called a state plan amendment, or SPA, to allow Medicaid reimbursement to non-licensed professionals for certain preventive services. We figured that asthma home visiting services provided by community health workers, promotores, and others would fit perfectly with this rule. This led us to years of advocacy efforts that included direct advocacy with the state Medicaid agency, 2 pieces of legislation, and a complicated process through the California budget system. In 2019, the governor and California legislature essentially said, we're not going to pass these policies at this time, but we will allocate $15 million toward asthma home visiting services. So for the past 2 years, we have been helping with the implementation of those funds. It is being run as a grant program through the Sierra Health Foundation, and we at RAMP are providing technical assistance. We are 2 years into the 3-year grant that is funding 28 organizations in diverse communities across the state to provide asthma home visiting services. This grant has really helped build the capacity of the workforce and of diverse organizations to engage in this work, and it has provided much needed services to many Californians with poorly controlled asthma. However, as wonderful as these services have been, it is yet another grant program, and to sustain services, we really need policy change. Luckily, over the past several months, we are finally seeing success in this area with two complementary policies. The first is the Asthma Preventive Services State Plan Amendment. As I explained, our efforts in 2015 began with the idea of a state plan amendment to allow Medicaid reimbursement to non-licensed professionals for asthma home visiting services. We recently made some headway and have worked with the state Medicaid agency, the Department of Healthcare Services, to draft the SPA. If approved, the SPA will allow reimbursement to non-licensed professionals to conduct in-home asthma education and environmental assessments. Notably, it would not cover the environmental trigger remediation, which I'll get to later. So where are we with this process? The Department of Healthcare Services has already submitted a draft plan to the federal agency for feedback. Once they receive feedback and submit a revised version, it will hopefully be approved, and they're planning on a July 1st launch date. Now, the state plan amendment is pretty skeletal in terms of what it defines for policy. So following its approval, the department will then need to draft policy guidance that really gets into the details. This will include working on codes and rates for reimbursement. And we, of course, plan to continue working with them on those critical components of this policy. It's worth noting that the asthma SPA will go hand in hand with a new SPA that California is developing for broad reimbursement to the field of community health workers, which we find really exciting as well. So as I mentioned, the problem with the SPA is that it doesn't cover environmental trigger remediation, and that's where the second policy comes in. CalAIM is a new multi-year initiative by the Department of Healthcare Services to implement broad delivery system, program, and payment reform across California's Medicaid system, which is called Medi-Cal. One of the major components of CalAIM is called community supports. Community supports are also known as, quote, in lieu of services. They are provided as a substitute for traditional medical services to avoid the utilization of other more costly services, like hospitalization or emergency department visits. The Community Supports Program provides a menu of 14 services that managed care plans can choose to integrate into their programs. And this is a really important piece because plans have to opt in. And when they opt in, they can select 1, 2, or up to 14 of these services. So the first group of plans opted in for January 1st start date, and then they have the option to opt in or add more every 6 months. One of the community supports options, the one that we directly advocated for, of course, is called Asthma Remediation. It would be made available to Medi-Cal beneficiaries with poorly controlled asthma. It will support minor to moderate environmental remediation with a lifetime cap of $7,500. It can include supplies such as vacuums, dehumidifiers, air purifiers, or services such as minor mold removal or ventilation improvements or integrated pest management. It is important to note that the policy language also includes, quote, other interventions identified to be medically appropriate and cost-effective. This is really important for ensuring that these interventions can be tailored to the needs of each client. So where are we with this process? As I said, the first step is that managed care plans are already selecting which community supports they will opt into. 17 plans have opted into asthma remediation, which will cover services across 36 counties in California. Then the plans that opted in to this service will contract with asthma remediation providers. And the policy language explains that asthma remediation providers must have experience and expertise with providing these unique services. They list examples of the types of organizations that you might contract with, which includes lung health organizations, healthy housing organizations, local health departments, community clinics, or community organizations. When they develop the contracts with the providers, they will then specify the payments and the billing, as well as defining the services. So then the next steps will be that the contracted programs will start providing the services, and then hopefully additional managed care plans will opt in at the 6-month increment. They can also opt out every 12 months if they find that it is not going well. So these 2 policy wins are really huge for California. So what are the keys to success? I think there are 3. The first is persistence. As you saw in the timeline, this work took literally years. The second is engagement with decision makers, which in our case, we were targeting the state Medicaid agency, which is the Department of Healthcare Services. And we built relationships with leadership. And I will say that since it took so many years, leadership changed a couple of times and we had to build new relationships. But each time we would make the case, share the concerns and needs of the community, and really work with them to see if there was a way to partner on these changes. And then the last one is the critical piece that is essential to all of our work, and that is partnerships. So this is a partial list of the partners that have worked with us on these efforts. The 2 whose logos you see, Children Now and the California Pan-Ethnic Health Network, have been working hand in hand with RAMP over the years on the policy change. But a huge network of other organizations have also been critical to these successes. Some of these groups were actively engaged in advocacy. They would provide testimony about the impact of this work. Others were not directly engaged in advocacy, but provided important information like data or research that we were able to use to support our efforts. So while we are rightly celebrating our policy successes, of course we all know that the real impact is in the implementation of policies, and that there are always challenges when moving from policy to implementation. So here are a few that we're anticipating. Successful implementation will rely on referrals from licensed providers. So how can we as a network ensure that providers know about the availability of these services and the process for referrals? We're already seeing that managed care plans are interpreting coverage policies differently. Some are saying that they will only reimburse for the cost of the supplies themselves. Others recognize that the comprehensive set of services, including outreach, education, and the behind-the-scenes administration, need to be paid for. So we'll work with plans as well as the state agency to try to sort this out. We also know that some of the asthma home visiting programs are based at community-based organizations, and that not everybody has the experience with or the current capacity to partner with managed care plans. Things around data sharing, billing, negotiating contracts is something that a lot of groups will need to build their capacity in. We are supporting them with that, and the state is also allocating some capacity building funds. And then the last challenge is that, at least in the case of the state plan amendment, we don't know what the funding levels will be. And we really want to make sure that the reimbursement rates are enough to actually sustain programs and to ensure a livable wage for the people providing these services. So, of course, we and our partners will be monitoring implementation, seeing if these or other challenges really do surface, and then working collectively on solutions. So the big picture is that fully implemented, these policies have the potential to significantly expand access to these critical services and to help sustain asthma home visiting programs. We hope that this work can serve as a model for others, yet we recognize that the approach is going to vary state by state. And so as a final slide, I want to share that we are partnering with the National Center for Healthy Housing to provide technical assistance on this exact topic, on building systems to sustain home-based asthma services. The technical assistance is free and tailored to the needs and interests of the participant. And for more information, you can contact my colleague, Joel, or our colleague at the National Center for Healthy Housing, Laura Fudala, and their information is there. And thank you so much for your time today. With that, I will turn it back.
Thank you so much, Anne. Really appreciated your presentation. And please, if you have questions for Anne, put them into the chat box, and we will get to those in just a moment. But first, I'm going to introduce my colleague, Barbara Kaplan, who is the National Director of Asthma Programs for the American Lung Association, to speak about some of our Asthma Awareness Month activities. Thanks, Barbara.
Thanks, Hannah. All right, well, it is National Asthma Awareness Month, and the American Lung Association is raising awareness among people with asthma and caregivers. And some of the topics that we are highlighting in May includes asthma control, emerging asthma treatment options, and the importance of air quality. If we go to the next slide. So we encourage you to visit lung.org/asthma to learn more about all of our asthma resources that will be available and we will be highlighting throughout the month of May. In addition, the American Lung Association educates healthcare professionals, health educators, and others to provide asthma guidelines-based care by participating in our Asthma Educator Institute. The registration for this 3-day virtual event starting June 7th is open. So if you'd like to learn more about the Asthma Educator Institute or to register, we encourage you to come visit us at lung.org/AEI, where you can learn more about the course and you can register for the upcoming event. Also during Asthma Awareness Month, the Lung Association will be promoting Asthma Basics, which is our free online course educating parents, school personnel, and other caregivers all about asthma. This program teaches participants to recognize and manage triggers, to understand the value of an asthma action plan, and to recognize and respond to a breathing emergency. You can participate in this program, or you can share information with your constituents. You can go to our URL, lung.org/asthma-basics, and that will get you more information about the program and how to register. Okay, we go to the next slide. So this Asthma Awareness Month, I thought I would just mention one of the areas that we'll be focusing on is around emerging treatment options. So we'll be raising awareness about 2 therapies that are out there. The single maintenance and reliever therapy, or SMART therapy, which many of you may be familiar with. And then there's a new emerging treatment option that was just published in the New England Journal of Medicine around the patient-activated reliever trigger inhaled corticosteroid, or PARTIX approach. So just to review both of these approaches, SMART, as you may be aware, was included as part of the National Asthma Guidelines 2020 Focus Update. And with SMART therapy, patients are using one inhaler every day to prevent asthma symptoms and using the same inhaler to treat asthma symptoms once they start. The medication used for SMART is a combination of an inhaled steroid along with a long-acting beta-2 agonist, or a LABA, called formoterol. And currently, this combination is available in the United States as budesonide formoterol or mometasone formoterol, so Symbicort or Dulera. The best candidates for SMART are patients who are ages 5 and older with moderate persistent asthma, or those who are in step 3 or 4 of the asthma treatment guidelines, and also who are not very well controlled despite low doses of corticosteroids, inhaled corticosteroids. So that's a little about SMART, and SMART's been available, an available treatment option. And then the other one that has just been published is called PARTIX. The PARTIX approach was recently published in the New England Journal of Medicine from a study that was funded by the Patient-Centered Outcomes Research Institute called PREPARE, or the Person Empowered Asthma Release Study. And this study was specifically created to find a way to help improve asthma outcomes for Black and Hispanic Latinx populations. So the primary outcome for this study was severe asthma exacerbations, and secondary outcomes included asthma control, measured by the asthma control test, quality of life as measured by the asthma symptom utility index, and patient-reported missed days of work, school, or usual activities. Safety was also assessed. What was really interesting about this study is that it was specifically conducted with Black and Hispanic Latinx patients, which a lot of other studies have not included or focused specifically on these populations that are so highly impacted by asthma. And then the other thing that I wanted to mention specifically are just a couple of the comparisons regarding these two approaches. In the SMART studies, this was a sort of a broad clinical trial. So like with Pardix, that was focused on Black and Hispanic Latinx patients. So that's one difference between these therapies, but both of them are used for patients with moderate to severe asthma. In the Pardix, this PREPARE study that was just published, one of the things that was highlighted in the journal article was the fact that there was a large portion of this population that used nebulizers, and that wasn't something that was looked at or considered in the SMART studies. So that was something that I thought was really interesting to consider in this one. And then also, I think for this topic that we're talking about today, you know, things to consider with either of these therapies are, you know, is prior authorization needed for either approach? In the terms of SMART, I believe, and for Pardix, I believe a prior authorization may need to be included. And because with SMART therapy, you're using your inhaler both for your daily control and for when you are having symptoms. You may be using that medication more than once a month, so you may need additional medication before your 30-day limit is up. And with Pardix, you may run into that as well. With Pardix, another thing that was interesting about that study is it was an add-on therapy. So this was in addition to your usual treatment plan with your healthcare provider. So this would just be adding on your inhaled corticosteroid in addition to your usual treatment when you were having symptoms. So I think a couple of things to consider with these and a couple of the questions that we're raising for Asthma Awareness Month is, you know, are physicians prescribing SMART? Are patients aware of either of these treatment options? And how we can empower patients to really start to have those conversations if they're not managing their asthma well. And then lastly, you know, are insurers or Medicaid reimbursing for these treatment approaches? So those are a few things that we'll be raising Awareness Month and talking about during Asthma Awareness Month. And if we go to the next slide, I also wanted to highlight that the American Lung Association collaborated with a broad multidisciplinary group of asthma specialists, medical professionals, and public health and policy experts to update the National Asthma Public Policy Agenda. This consensus process resulted in 22 public policy recommendations that are grouped in 6 major categories, which include public health infrastructure and surveillance, outdoor air, healthcare systems and financing, homes, schools, and workplaces. Many of the policies and supporting strategies in these categories were updated to reflect the latest science. The original National Asthma Public Policy Agenda was published in 2009, so this really is just looking at the latest science and updating those policies. We will be having a webinar on June 1st at 3 p.m. Eastern to share some of the key findings from the update. So look for more information. We'll be sending out some information on how to register during Asthma Awareness Month. All right, and with that, it's my pleasure to turn the presentation over to Erica to speak about some of our federal activities for Asthma Awareness Month.
Thank you so much, Barbara, and good to see everyone today. Thanks so much for joining us. So I want to just take 1 second to talk a little bit about what we are doing from a policy perspective around Asthma Awareness Month. One is to make people aware about the Elijah E. Cummings Family Asthma Act, which is HR 7055. It is legislation that supports and would expand the CDC's National Asthma Control Program. And we are doing similar activities, particularly with our partner organizations, around educating members of Congress about the importance of funding for the CDC National Asthma Control Program as well, both to ensure additional states are included, but also to ensure that there is adequate surveillance across the country as part of all of this. So wanted to bring those 2 activities to your awareness and your radar as well. So with that, I'm very pleased to start to begin our question and answer session. Do have a few questions ready that have been posed, and I'm going to direct the first one to Hannah. As I ask her, I would encourage anyone else who has questions to please chat them into the Q&A box. So Hannah, when approaching policymakers about expanding Medicaid coverage, they often have questions about cost. Do you have any data on cost to expand some of these coverage areas and what that would cost the state Medicaid program?
Sure. So there are 2 resources that I would point you to on our website, which is, once again, lung.org/asthma-care-coverage. One is a piece that we put together on the return on investment of asthma coverage. And I think often framing these interventions in that way can be helpful for decision makers because we know that a lot of patients who could really benefit from services like asthma home visiting are showing up in the emergency room multiple times a year. Those interventions, those interactions with the medical system are very expensive, and so there's a lot of research that has been done, especially around areas like home visiting and self-management education programs, that show that for a relatively small investment up front, you can avoid a lot of more expensive healthcare costs down the road. So there's a brief on our website that provides just like an overview of the research in that area that I think could be helpful for the question that you asked. And then the second piece I'll refer you to is a couple of years ago, we did brought together a group of state asthma programs who have done a lot of work in this area, and they kind of shared their best practices, their tips and tricks for working with their Medicaid colleagues to advance coverage of asthma guidelines-based care. And a lot of what we talked about in that group is related to cost and how they framed it and where they got the data in sort of their specific states that they found most helpful, how they got that data and how they presented it in a compelling way. So I think those are 2 really great places to start for that question.
Wonderful, thank you. Our next question is for Anne. Anne, what advice would you have for other states on how to expand coverage of home visits through this pathway?
Yeah, thank you. That's a great question. I think in thinking about this question, I would go back to the keys to success that I highlighted. And so one is relationship building. So build relationships with the decision makers, whomever they may be. In our case, we were targeting the state Medicaid agency, and so we built relationships with them. We also did some work with the legislature, built relationships with them. In other states or in your community, it may make more sense to go directly to the managed care plan and build relationships with the leadership there. So investing the time to determine at what level you want your policy decision to be made, figuring out who the decision makers are, and then building those necessary relationships is critical. And then the other one is really the partnerships with those doing this work. So really draw upon the wisdom and experience of the people that are actually providing these services in your community or state, figuring out what their greatest challenges and needs are, which of those challenges can be addressed through policy change, what they would like to see in a policy change. So really spending some time working directly with those providing services. And then as you're doing both of those, you can reach out to us in the National Center for Healthy Housing for technical assistance, where we can really look at what's going on in your community or state and help think about which policy changes might be the best fit and how you can take the initial steps to pursue those.
Wonderful. Thanks so much.
Thank you.
Now, my favorite question is, are the slides going to be made available after this presentation? And I will share that the recorded webinar today will be up on our website for people to be able to access. Okay, next question. What are the implications of the PREPARE study for Medicaid coverage? Hannah or Barbara, do you want to take that one?
Yeah, I can start.
You want to start? Yeah, great.
I think Barbara identified a couple, especially around we're still sort of figuring out if both for SMART and this newer intervention, sort of if the quantity limits that plans in Medicaid have in place are kind of working well for patients or preventing them from trying out these new therapies, if that's what their providers think is best. The other thing I will just flag that I think is really interesting about the PREPARE study is how many patients are using nebulizers. And I think a lot of times we focus, on we track so many medications in this project and we focus on the coverage of them. But if patients are really relying on nebulizers heavily, then I think, taking a close look at your state's coverage of nebulizers and any barriers to care there it would be an important sort of next step. Anything else you'd add to that, Barbara?
No, I think both of those sound like right on. And it was such a surprise to see the amount of patients using nebulizers. I think is just something to maybe even pay attention to, as the authors point out in the study. So,
who should I contact if I want to discuss my state's coverage data was another question.
The Lung Association, we have a website, asthmacare@lung.org, that you can email if you have any questions about your state's coverage data. The other thing I will offer is that if you are part of a state asthma coalition or another similar group having kind of an annual meeting on asthma or anything like that, and you would like someone from the Lung Association to come and sort of do a deeper dive into your state's coverage data, please just send us an email, and we're happy to try and make that happen.
Great. I think that concludes the questions for the webinar today. Hannah, is there anything you want to say in closing?
No, I just want to thank everyone for their time today. There will be a short survey at the end of the webcast, so if you can stay on for these last couple of minutes and fill that out, we would really appreciate it.
Wonderful. Well, I want to say thank you to everyone for your time and interest in this very important subject, to our speakers, Anne, Barbara, and Hannah, and wish you all a very active and good Asthma Awareness Month. So thank you so much and have a great afternoon.